When we engage with a new client to create a quality submission for them, and they start looking for their data, what are the common surprises that they're running into? What are the common challenges?
A number of challenges I think are really surprising our ACO clients. Probably the first or the most predominant surprise are the the restrictions of a contract, either the contract with the vendor, the EHR vendor, or even sometimes restrictions within the ACO membership, who can see whose data, or the EHR vendors may have restricted what kinds of data the clients can extract from their systems. So it's contract limitations that are starting to show up in some of these conversations. And so we need to sometimes go back to the table, get partners to talk to each other, come up with new agreements by way of exchanging data. Sometimes clients will need to renegotiate vendor contracts so they get access to more data types, more data extraction or extraction tools. That's one thing that we're seeing as a kind of a surprise to vendors or to clients who are working with the process of collecting numerator data. Another challenge has been the volume of the data. So one of the measures, especially measure 134, the depression measure, has a very broad denominator. Most of the encounters in an ambulatory care environment are going to qualify for that measure. So I think one of the other surprises clients are finding is the sheer volume that they are finding reported for these three measures. And when you're thinking about if you do have a data gap and you are reporting 300 patients for a quality measure versus 3,000 patients, that data gap can really translate to a lot more manual effort to report the quality measure. So just much higher volumes than might have been expected. That leads to much higher than expected chart abstraction costs to collect all the data needed for the meeting the reporting rate or meeting a performance goal.
Now, just a point of clarification for me, Laura. You're describing a lot of different ways of getting this data and the surprises around them. Um, in these complex organizations that are ACOs, do they have to they have to come up with the same way for each of their practices of getting data to us?
They do not. That's sort of the nice thing about being able to work with a registry is that a registry has the flexibility to combine the data in whatever form it's being found in all of these member practices. So for example, if some member practices are very mature have very mature workflows on their EHR product, they're collecting a lot of really good, robust data that they can export, for example, as a QRDA1, that's a great way for us to leverage all of the data they've collected and help them avoid any chart reviews by way of reporting the data. Other members within that same ACO might still be on paper practices, might be struggling to switch from one EHR to another EHR during the year. So registries can really come in and pull the right data at the right time to fully and accurately define the denominator and the numerator for these clients. So we can use chart review, we can help clients start collecting quality codes in their workflow, whatever they are able to do by way of helping them report to the reporting rate requirement, the data completeness, and also their performance goal. We can work with those goals on the ground.